Hi, I'm Christina Cowger, licensed psychotherapist and health educator, here today with Dr. Decker Weiss, cardiologist. So when I looked at the neurocardio panel, I saw that there were numerous panels with numerous markers and a variation in the different panels. Before you had access to a test, let's say like this neurocardio, how are you piecing this together? I suspect you were considering inflammation before. How is this making it different in your practice clinically?
Well, it's a game changer.
Okay.
It's a complete game changer because before, sometimes I'd run cytokines if I was worried about immediate risk and had to go isolate one separate panel, charge them, run it through insurance, whatever it is. It was a whole headache to do that. And then some people I had to do neurotransmitters with if I thought that. Other people I would do a standard myeloperoxidase, C-reactive protein, and then the new oxidized LDL marker. Now it's in one package. Now I run all of those, I run that full neurocardiac at their first visit, and then within 1 month, I run the neurotransmitters and the cytokines. And the reason is patients want to know within a month if they're getting better. They come in, they'll buy some nutritional supplements, I'm asking them to change their life, I'm asking them to change everything maybe about their life, even relationships. I mean, I'm asking them to look at the core of how they go about every day and change it. But they don't want to wait 3 months. They don't want to wait 6 months, a year to find out if they've actually done anything. That's the beauty about neurotransmitters and cytokines. They'll change and modify and improve within a month. So you can see that if your treatment's on the right track. You can see if the patient's being compliant. Or maybe you're missing it altogether and you need to take a new look at a patient. But rather than waiting 3 months to a year and finding out because they just had a heart attack that what you're doing isn't working, you know within 1 month.
Got it. So in how we've approached cardiovascular disease over the last, let's say, 2 decades, what would the standard of care have been? Would it have been come in and we'll run cholesterol panel and you'll come back in 6 months, 12 months? What's the difference as far as clinically for you?
I mean, this is kind of embarrassing, frankly. It really never strayed from a standard lipid panel. I mean, even when C-reactive protein came out, the high sensitivity C-reactive protein came out, most cardiologists never ran it because there really wasn't a drug for it. So they'd be like, yeah, I guess statins can help lower that, so they might add it in, they might not. So it really never changed from the gold standard of a lipid panel. Now the lipid panel went from 4 or 5 different things and it broke it up in all these little pieces. But at the end, they just ended up on statin therapy. It was just another reason to put them on statin or cholesterol lowering therapy in general.
So Dr. Weiss, as a woman, I have a special interest in cardiovascular disease and how it relates to women. And when I was reading some of the data, it seemed that men far outweigh women statistically in cardiovascular disease until women hit this midlife point and beyond. And then it seems, and clarify me if I'm wrong, but it seems like the rates almost equal out at that point.
Do. Women go from 1 in 7 premenopausal to 1 in 3, postmenopausal or during it. We're not exactly sure what day that occurs, right? Like when does that exactly occur? We don't know. And that's why everybody thought estrogen. Right? So we're going to give them all estrogen and then their hearts are all going to be better. But we didn't give women estrogen. We gave them synthetic copies and dangerous copies of estrogens. So we don't really know what a good bioidentical hormone is going to do, other than we know low estrogen states the vascular walls become damaged, the endothelial lining can become damaged. Women need estrogen postmenopausally to maintain the lining of their blood vessels. But it's intimately related also to serotonin levels. Now, there's all sorts of arguments about exactly the estrogen-serotonin links, and they get real complex. What I can tell you is we're not really settled on exactly the interaction, but we do know that you have to run them both. So if a doc is going to use bioidentical hormones and look at estrogen, they have to run serotonin levels to make sure that the estrogens can be effective, or maybe to see how much estrogen they really need. Maybe by boosting serotonin, they don't quite need as much estrogen or estradiol, and they can lower their risk exposure.
So let's say with a patient that comes into your office as a cardiologist that has, let's say, family history, but relatively normal weight, maybe slightly postmenopausal. Would you look at doing something like the neurocardio panel and adding in then the hormones? Is that how you would approach a patient like that?
And I'm going to take that a step further. If we don't run serotonins as heart panels, within 10 years that'll be malpractice. So I'm saying that right now in 2014. If you do not on a woman run serotonin as part of a heart panel, it should be considered malpractice, because the data coming out with healthy estrogen levels, maintaining vascular linings, and its relationship to serotonin is so in our face and so obvious. And women have been telling us. They've been telling us, they've been saying, I don't feel well, my moods are down. And what did docs do? Good old boys club. Oh, they're just postmenopausal or whatever, right? And women were dismissed. And shame on us. Did a terrible job of it.
And it also seems statistically, when you look at the numbers, that this crossroads, this menopausal crossroads that women experience, not only does the cardiovascular rate jump, but we see a lot of, and I'm going to use the word that's being used everywhere now, inflammation. We see the fibromyalgia spike rates of it. We see inflammatory issues start to really crop up at midlife. And it seems from at least what I've been looking at, that the cardiovascular piece wasn't in all that other literature. So we it seems like we need to really put that together, that this is almost an inflammatory crossroads for women at this midlife.
Yeah, and also what's happening is they're treating menopause during menopause when you needed to treat it when they were 40 and 45 and get them ready to launch into it. Simply put, when we're looking at specifically women and heart disease, you said it earlier, hormone panel, neurotransmitter panel, then you get the cytokines, and then you'll get the ApoBs and the myeloperoxidase and the oxidized LDLs. Women, you always have to go to another level to truly assess, especially with the hormones, because they're complex. In a world of a lot of women using bioidentical hormones, they're running those every 3 to 6 months anyway, or they should be, to make sure that those levels are safe and accurate. But you're right. I mean, the women's heart panel is going to have serotonin, but you're also going to have estradiol, estriol, estrone, progesterone, and DHEA as part of those as well. Now, that is when we're going to really prevent.
Very exciting.
That's when the cancer docs and the heart docs can actually have a conversation about not shipping women back and forth between our offices.
Fabulous. Fabulous. So the neurocardio, where do you see this taking cardiovascular disease assessment and management?
The lipid panel is over. It's over the day that this is launched. Now, not everybody's going to know that, but the neurocardio panel will replace every cardiovascular panel in the world eventually. It's how long doctors are going to be willing to accept it, how long other companies are going to market against it. There is no other place to go but looking at immediate risk and the underlying, central nervous system control. There is no place to go when at an age where we finally have recognized depression as a risk factor, that we're going to have to run serotonin and norepinephrine levels. There is no other place. The data is here, it is overwhelming, and it is going to be a sad goodbye, but goodbye lipid panel. It's time for neurocardio. And it's a good day for patients, a really good day.
And as a cardiologist, I'm imagining that it's going to allow cardiologists in general, doctors in general, to not miss a whole spectrum of the population that really has been at risk.
Look, we're seeing kids 35 and 40 having heart attacks.
Wow.
I mean, it's getting younger and younger as our food is getting worse and as the pressure is going up, as the stimulant use is getting over and over. We're going to be able to look at these kids and go, yeah, you may not have a C-reactive protein elevated because you're 35, but your neurotransmitters are having these issues and your cytokines are, and it's a race between cancer and heart disease, and you're way too young to have it. Absolutely, it's early warning, it's current state of risk, it takes you across every panel, every boundary that we need to do as cardiologists. And also, let's not forget that I get to be a much better doctor. Look, I can target my therapies. Gotta confess, I'm a good guesser. I have been guessing on supplements for 14 years on my patients, and I've used science, but I haven't known specifically that person needed high gamma E or that person was absolutely perfect for alpha lipoic acid. But I've used those things and I've been very, very successful in my practice. I've only had 2 patients have heart attacks in my whole 14 years. Other than when it was their time, which was both over 88 years old, and both of those 2 patients, it was their time. Wow. So, I'm in thousands and thousands of patients. Other things will get them. So it hasn't been their heart, and I've been able to get heart failure under control. I've been able to get these things going by being a real good guesser. Neurocardio is the beginning of the end of me guessing. I can target serotonin with 5-HTP, I can target methylation issues. I can target their cytokines and use natural botanical anti-inflammatories to get those down, or lifestyle. I can target with antioxidants using, alpha lipoic acid, D and K and, E to get their oxidized LDLs down. I can target across all of those parameters specifically. And they change. So at 35, they're one thing.
That's right.
All of a sudden at 45, they're coming out of a bad marriage. And so I've got to look at central nervous system support. And at 55, they're in a good marriage, and they don't need so much of that.
So it's
but
a
they got
wide
fat
net.
but they got fat and stopped exercising because they're in a good marriage, and so now I got to look at their inflammation. I can target it specifically. I'll be so much of a better doctor.
So this neurocardio is a fairly wide net.
Yeah.
We can start earlier, monitor more effectively. And how would you recommend in your practice when you do the neurocardio, you start with the more extensive test panel, you do a follow-up in a month,
Yeah,
3
so
months, 6 months?
113 is where I like to start it. So
Okay.
full cardiac panel, neurocardiac panel, which includes the MPO, ApoB-ApoA1 ratio, myeloperoxidase, oxidized LDL, with the cytokine panels that we've chosen, the interleukin 6, 8, 10, TNF-alpha, and interleukin 17. That gives us the immediate risk, as well as the inflammatory atherosclerotic piece, as well as the endothelial function, along with the neurotransmitters, serotonin, norepinephrine, taurine, glycine, glutamate, DOPAC. DOPAC looking at sort of this oxidation bridge. That's a full panel. Then at 1 month, we don't have to rerun the tissue markers. We don't have to run the C-reactive proteins and ApoB-A1s. They're not going to change that quick. They take longer. But the cytokines and neurotransmitters, they need to change within a month. They need to improve within a month. And I can sit across from a patient and go, look, I can do these things. How much do you want to participate? Doc them in. Great. I'm going to be within 1 month. I'm going to show you that we can get this to improve. Versus, hey, in 6 months we'll relook at the lab and see
How
what we're doing.
motivating for patients.
Oh, it's completely motivating, and it's such a better model. And patients get excited. Look,
Compliance goes
I'm
up.
better. And then they feel better. Then their neurotransmitters are better, right? And then they're, you know what, maybe not eating fast food and going to
Is
the
really
salad
gonna have
bar
a
is really
payoff.
working. Yeah. And so you got to win patients.
Great.
You got to win them one at a time, and the neurocardio allows me to do that.
Thank you for joining us today, Dr. Weiss, and for bringing a wealth of information about the state of cardiovascular disease and testing and where we're going. Thanks for the great information. Thanks for being here.
Glad to be here. Glad to bring you neurocardio.
Thank you.